The registrars that we have are the doctors that will be the doctors in future, and we don't know what that future is yet. The practices we're training them in are the practices that function in today's world, with today's medicine and today's billing and today's society and expectations. And the doctors who are training them are people like me, who grew up in medicine a long time ago and trained in a totally different world that was different again. And how do we make that work? And how do we go into the future with these older people in a modern world that's ever yet changing? So that's the premise of what we're trying to talk about. So to start with, and you can read it's one of my favourite Woody Allen films. Actually, in the same film, there's a moment where he comes out of the time machine and is awake. Sorry, not the time machine, he's been asleep. And he wakes up and he's stumbling around and all disoriented and he can't do anything at all. And someone lights up a cigarette and shoves it in his mouth and says, "Here, that'll help." And he said, "Oh, probably when you fell asleep, they thought these things were bad for you." So, can anyone tell me a time or something about medicine that has changed completely since you graduated? Sorry? Hilton? Yes? So, because we're recording, it's really important. Beta blockers used to be contraindicated in heart failure. And now, Hilton? They are now the treatment. How do we cope with this? Nick? Admitting patients in hospital to start an ACE inhibitor. Or at the very least, as I recall it, with the first dose of captopril, if you didn't have them in hospital, they had to go to an emergency department, have their first dose and lie down for at least an hour before they're allowed to go home. Yep? Michael? You only started in practice yesterday. How could this be true? Yes? So for those who didn't get that, children with their first urinary tract infection would be extensively and invasively investigated. Amen. Yep. So post-MI, patients would be kept absolutely still in bed for 14 days in hospital, and now, Eamon? Now they get out the next day. See, I knew I didn't need to have my own ones. Bruce?
Turns out that gastric ulcers are not caused by smoking, bad lifestyle, stress, and your blood group.
Gastric ulcers are not caused by smoking, bad lifestyle, stress, and your blood group. What are they caused by? Bacteria. Yes, they're caused by bacteria. And a crazy guy, no one believed him, so what did he do? He drank the bacteria, got an ulcer, had the antibiotics, healed it, and said, "Cop that." Of course, that happened hundreds of years ago with cowpox and smallpox. I'll infect my family, won't I? I'll have one more. So cataract surgery, had to lie in sandbags for, it was a week when I was a resident. How long was it when you were a resident? A week, couldn't move, patches covered up, and you'd have the big reveal. And now it's a day procedure. And of course, the difference is also implantable lenses instead of Coke bottle glasses. There's millions more. Isn't it fascinating? And yet, all of you who are currently practicing today, do you do any of those old things? So what I want you to think about while I talk, because I'm pretty boring and you have to think about something, I want you to think about how on earth have you done that? What are the steps and processes that you've put in place that have allowed you to transition from any or all of those things, depending when you graduated, to practicing the medicine as you do it today? That is the key thing I would like you to think about this morning. That is, I think, the central part of how we can help registrars and the doctors of the future cope. So if you haven't finished with Woody Allen, bad luck, it's time to move on. So that's it. That's my key question. How do we adapt? And that's the word I'd like you to think about. In the meantime, we'll entertain you with some other stuff. What do you think? So in case you didn't know who... I didn't bring my chocolates. I'll have them for my Pecha Kucha later. So Wayne Gretzky is probably the most famous ice hockey player. And people always asked him why he was so good. And that's what he would say. People skate toward the puck. I skate to where the puck is going to be. And it's the most perfect capture of dealing with the future. And sometimes, and we had Craig Rispin here yesterday, Even he eventually admitted that futurists don't always actually get that right, and I'm sure Wayne Gretzky didn't always get it right. But when you get it right, it's fantastic. You're there and suddenly you're the only person there with the puck and you know what's going. And we have to think not about where is medicine, as the educators and developers of what's happening, we have to think about where is the puck going to be next year, 5 years' time, where is it going to be for this registrar when they're a supervisor? So if we can contemplate that, and then we've got to build in how can we use our adaptation skills to get there. So these are things I want to cover in whatever I have left of my time that Michael's timing for me. The first one is just a point I'll make now. 20 years ago, we had a medical education meeting and we had a debate, which was supposed to be funny. I was the only person who was funny, but that's because I was on the wrong side. I had to defend evidence-based medicine. And even though we were the far more brilliant team, we got booed, quite literally, and we lost heavily on a public vote. If you had the same thing now, I think you could defend evidence-based medicine, say almost nothing, and you would still win. And now every time I turn around and look at someone, or just pick up a pen to write a script, people ask me, what's the evidence for that, John? So that debate is over. Everyone wants evidence, not just in medicine, but in education and in almost everything else we look at or sneeze at. So that's gone. So we need to now think to justify. Of course, what we all know is, what about all the stuff we don't have evidence for? This is where the human part comes back in, that the futurists haven't got a handle on yet. I'm going to talk a little bit about those other things on the list as we go through. So a slide, I cut off Paul Glazio's name in the refit. I'm very sorry about that. But Paul's a wonderful fellow local here at Bond University. It's old beach data. It's a brilliant slide. 30 conditions on beach cover 50% of general practice consultations. And 800 plus conditions cover the rest. What does that mean for junior learning doctors? What does it mean for how we progress? If you think of the Sackett, in the beginning of evidence-based practice, he divided into just-in-case learning. This is the stuff you need to know all the time and know really well to get you through your day. If you know those conditions as a first-term registrar during that first 6 months, just-in-case learning, you will handle 50% of stuff and stop asking questions and be really competent in those things. And the other one, the just-in-time learning, the stuff you look for the evidence. The stuff, as a registrar, you get help from your supervisor. This is what we have to teach people not to have to know, but to have to find out. Of course, the one problem is, I'm told to put a couple of really good graphs in here. So, the problem is, if you don't know or aren't aware of those other 800 conditions, you're going to miss them all. So you have to know really, really well the 30 conditions, but you have to know that the other 800 exist, and they could be what's happening. And you have to have skills to look, search, find information, to recognise patterns, to realise it may be something different, and to know that you need help from the internet, from a colleague, from crowdsource, whatever you like. But you have to be able to do that. You can't just sit back and say, I'll work on the 30. Because that's where we go wrong and that's where we miss things. I'll get a little bit more about that later on. But can we assess progress? If we're really looking at genuine in-training assessment, I probably want all of the registrars in that first 6 month term to get their head around those 30 conditions and to manage them independently and functioning really, really well. Forget about exams. That's because then they can concentrate on how to learn, discern, take a good history and recognise the patterns for the times where it's not in that 30 or it doesn't fit, and go for help and work out what to do. Some things don't change. A wonderful former president of Wonka, Rich Roberts, has this great theory that we still know that no matter how everything else changes, mortality is still one each. And I don't know about you, when I read the press, I get the feeling and the futuristic capability of everything that somehow or other, if only I was a better doctor, no one would ever die. And the answer is we will. It's a question of how and when and how will we support it and who will be there for us at the time. And I'm not reading you the jokes, you have to get them all for yourself. So, for some of us, if we listened to Craig yesterday, we could be fearful that winter is coming. But if, of course, you're the evil people north of the wall, winter coming is a really good thing. So, this is from ASME 2013, fairly recent, about where the world is going, and I probably don't have to reiterate too much of this because we've been talking about it. Who knows if we'll actually have a digital health system in Australia and records, but anyway, electronic health records. The third point is the one I'm interested in. We will have data that's genomic, phenomic, and all these other omics that people are talking about, and we'll have people with data that makes them an individual, not working on population-based studies, and that's coming very, very soon. Unlike my next slide thing, but it is now. And the knowledge cloud that will exist and already exists, this whole thing to source and find your way through, that someone is going to start to structure into meaningful things that will have scientific knowledge and best practice and guidelines and decision support tools all built into it. That's being built now. That's where we go for the 800 conditions. The slides got jumbled, but yeah, that's the rest of it. I don't want to spend time. But of course, the challenge with any such thing is accuracy, curation, and looking after it. And the whole problem with a whole lot of social media and foam is that it's not curated, and younger doctors run the risk of not being discerning. They'll learn really great critical thinking skills to look at a journal article, and they often won't apply that when they find a good blog site. So teaching people to critically analyse what's going and what's happening is really important. But the cloud will be able to answer our questions and offer us advice and help us with decisions. Who's already knows their own DNA? Get it online, send a swab off, they send you back a full report right now. I forget how much, but it's not very much, $200 I think. When's your first patient going to walk in your room and say, here's my DNA, here's my risk, what do I do about it? Has anyone had that happen already? It won't be long. We're going to have to make much more complex and individual decisions about people. That's going to change our medicine for the better, but it's going to change our decision making with great challenge. And you'll be able to know things like, am I the sort of person who responds to this drug? So it's going to influence our drug choice because we know genetically this person is more or less likely to respond to this drug over that drug, rather than here is my first line treatment for your condition. Here is my first line treatment for your condition according to your pharmaconomics for your particular genetic state. So we're going to have to make really complex decisions about people, and there'll be all sorts of things about inherited traits. Thanks to genetic testing, I was diagnosed with celiac disease in my early 50s, and I thought I was asymptomatic. I have one son with celiac disease, and I have an asymptomatic son who is not yet gene tested, but as soon as he's gene tested, we can map out a plan so he doesn't become a 50-year-old undiagnosed celiac. That he can be someone who will be diagnosed appropriately at whatever time, and also know if he has no risk. So it can change things really well, and even in my own family. But what's it do is we have this terrible challenge of making decisions with complex data. And you see that little flat yellow line at the bottom? That's our cognitive ability. And over time, the amount of information we get has made medicine and decision more difficult because we have more information. And we are exploding. 2 minutes to go. Awesome, thank you. We are exploding with the amount of information, as Craig showed us yesterday. We're getting people going to bring us a whole lot of data, and we have to make decisions beyond our capability to absorb and work with that data. And that's what the cloud's for, but don't forget the human element. We still need, as per the last question in the keynote yesterday, we need to take a history. We need to understand that history. We need to relate to the person, and we need to be able to work with the person on their advice and have them believe us. The best diagnostician in the world is a terrible doctor if no patient does what they ask them to do. So with the cloud, this is a very interesting slide and probably the thing I would like you to get the most from. If you don't know anything much, the cloud won't help you because you don't know the question to ask. If you know a fair bit but not enough, the cloud will help you a lot because you know what to ask and it will have the information in it. And if it's something you already know, you don't need to go to the cloud. So the cloud is not a scary place. What the problem is, knowing how much you know and having insight. And these are not things that technology is going to teach us. Our teachers are going to teach us. Remember this teacher? He's a pretty good guy. What a wonderful framework to still have. Someone was saying yesterday, the content may come or go in Murtaugh's book, but look at that strategy and approach. And I'm focusing in on the very last one. You're not going to get this. Maybe Watson can do it. I don't know. Watson can do that first lot, great. Can he do this? I'm not sure. Human beings can do this. You know, the interpretation of a person's emotion, their eye, their body language, the way they say things, your prior knowledge of a person is really critical to understand what's going on. And this is where the humanity connects to the technology for me. So communication is the key, and you have to be an Elton John fan for this one. Time? So, last 2 slides. This is really important in assessment. If you think you know and you're right, you're safe. If you think you're wrong and you're wrong, you're also safe. If you think you're wrong but you're right, you're mostly safe. If you think you're right but you're wrong, you're not safe at all. And this is where, again, insight, awareness is really critical. In research, you know this, we have leaks at every step. The research is published, but we don't do it at the bottom end for all the reasons. We don't remember, we don't try, we don't believe it, we don't read it, we don't access it. This is where FOMED is fantastic. Gives you access and capability. I don't know if any of you do, and I won't ask the question, but how many people bother to measure blood pressure in both arms first time you see a new patient? Because all the evidence says we should. And I said this many times and I still don't do it. So what have we learnt? I've learnt that you don't need any original thoughts at all to give a talk. Everything is borrowed and learnt from other people over time. The other thing I really hope that you learnt is that how you learnt to adapt from when you graduated to now is exactly the skill you need to give registrars, because you can't teach them what's going to happen. You can teach them how to adapt to what is going to happen. Thank you.